I'm Dr. Riyad, consultant psychiatrist in Royal Hospital, Sharjah, and I'm pleased to be here with you to introduce our first speaker, our Mr. Abian, future doctor, hopefully, inshallah, this year will be graduated. Mr. Abian Al-Yamani is a 6-year Omani medical student at Arabian Gulf University in Bahrain. In 2019, Abian was nominated by the Arabian Gulf University to participate in the first batch of the Medical Gifted and Talented Student Program. Since then, the student started working on multiple research projects related to metabolism and related genetic variants, global developmental delay, and autism spectrum disorder. He will be talking today. The title of his session is Children with Autism Spectrum Disorder, 20 Years Regarding Employment and Intimate Relationship. So, Mr. Abian. Abian, come here. You are sitting here. So please welcome Mr. Abian.
Can you show it only from there? Okay. Good evening, everybody. Thank you, Doctor, for introducing me. I'm Abian Ismail, medical student at the Arabian Gulf University. Today, I will be speaking about a study or a research that we have conducted between September and December in the last year, 2022. The title of the study is Children with Autism Spectrum Disorder, 20 Years Later. We are focusing on employment and intimate relationship. For disclosure, nothing to disclose. So for this presentation, the learning objectives: identify the risk factors associated with long-term ASD development or autism spectrum disorder development, assess the risk of cognitive deficit in the development of children diagnosed as autism spectrum disorder into adulthood, study the evolution of employment and education as evidence of good rehabilitation, and evaluate the effectiveness of rehabilitation efforts for adults with autism spectrum disorder. These are the objectives of our research. The first objective, to explore the type of relationship characteristics of adults with ASD, to explore the opportunities for employment among adults with ASD, to study the associated risk factors. We are meaning here gender, age of onset, use of medication, seizure, comorbidities that are affecting normal development in relation to the outcome, and to study the role of intellectual disability in achieving developmental tasks of adulthood for adults with ASD. So starting with introduction and literature review, in the previous researches and similar articles, we have found that early adulthood outcomes of cases diagnosed with ASD varies, and better long-term outcomes were found among cases with lower ASD severity, higher maternal education, and parent participation in the rehabilitation process. Lower IQ was found to be associated with increased irritability, hyperactivity, and need of medications. Frequent distributing symptoms of ASD patients in early adulthood includes language delay, stereotypes, attention deficit, behavioral disorders, aggression, sleep disorders, and impaired appetite. Defects in social interaction and communication skills among ASD patients affect their ability to form a healthy relationship, either friendships or intimate relationships. And regarding seizures, that we are going to talk about also as a comorbidity in ASD adults in this case, epilepsy occur more often in individuals with ASD than in general population. Actually, our study comes as a second step follow-up study that comes after a previous study that was a 10-year follow-up study in Bahrain. And the previous study, 10 years follow-up in Bahrain, investigated the outcomes of adolescents and young adults of ASD, focusing on their general functioning. And the results showed that most of the included cases attended daycare programs, and 10% of the cases were in regular schools. 25% of included cases had friends, and none had married or held a regular job. So talking about the methods, in this study we included 81 ASD individuals, and all of them were diagnosed by the DSM-4 at that time, in the period between 2000 and 2005, and cases whose primary diagnosis is not ASD were excluded from the sample. We have multiple sites that we recruited our sample from. So we recruited the ASD individuals attending Arashad Center and Youth Club in Bahrain, ASD individuals who were at Al Wafa Center and referred to school, and we reviewed the records at the psychiatric hospital from the Child Adolescent Psychiatry Unit at the Psychiatric Hospital in Bahrain for the study period. We mean between 2000 and 2005, those who were diagnosed at that time. And we also asked the parents of our samples who were included in the study if they have any personal contact and known cases that are not attending any center at present. Regarding data collection, we designed a data collection sheet that was designed for this study, and mothers of the ASD individuals were interviewed by phone call by a research team that was consisting by teachers from the centers that I have mentioned before, the Arashad and Al Wafa centers. And for those whose mothers cannot be interviewed or we were not able to reach their mothers, the father or the main caregiver was interviewed. And of course, informed consent was provided and signed by the mothers. We asked them to come and sign, and ethical approval was gained from the Research and Ethics Committee at the Arabian Gulf University in Bahrain. Statistical analysis was done by SPSS version 29. So here are the results that we have got. The sample size was 81, and the mean age of the sample that we have got was 22.65 years. The standard deviation is 4.1868 because we have a wide variation in the age from 17 years to 36 years old. The age of diagnosis, here it's in months. The mean age of diagnosis at months was 39.81 months, which is around 3.8 or 3.9 years at the age of diagnosis. The standard deviation was very high here, 19 months, because also we have a wide variation of age of diagnosis. Some of them were presenting late as 120 months, which is the maximum, and the minimum age of diagnosis was 17 months, which is around 1/2 a year. Gender, males were more than females, with a ratio of male to female 4:1. Males were 72.8 and females were 27.16. And we investigated also the social class by asking them about the father employment and the family income. And most of them were in the low to middle class. Here we asked the parents about the presence of intellectual disability. Actually, here in this point, we asked them about the reports that they have got from the psychiatric unit at Child and Adolescents Unit at the Psychiatric Hospital, because at that time there was no IQ test done for them, but it was like a cognitive assessment that were done for the children. So in the phone call interview, we asked the mothers if they were given a report that their child has intellectual disability or not. And 37.04%, which is around 30 out of 81 of the cases, had actual intellectual disability. By asking them about intellectual disability and by getting these results, we divided them into two groups. The first group was those who only have ASD and those who have ASD plus intellectual disability. And then by the other factors, we tried to see if this gives a poor outcome or not. Taking medications, 51.85, which is about half of the sample, around 42 out of the 81 were taking medications. Here in medications, we mean both antipsychotics and anti-epileptics, because some of them are taking risperidone and some of them are taking anti-epileptic medications because they have seizures, as we will see later. 25.93%, which is about a quarter of the sample, has seizures. Here we ask them about the family history, if they have other child in the nuclear family that has intellectual disability or autism spectrum disorder, and we got that around 10% of them has family history of similar disorders. Here we come to the intimate relationships and friendships. We ask them if the ASD adult or the individual has friendship or not. We ask them if they have children, yes, or if they have friends, yes or no. If the friends are from the same family or from the outside of the family, like from the school or from the neighborhood. And also we ask them if this is a long-standing relationship for more than 1 year or just like a short time friendship for less than 1 year. So what we got, males, 10 cases have friends, and 8 of those cases having friends for more than 1 year duration. And in females, 6 cases having friends and 4 cases having friends for over 1 year duration. And 10 cases from general, from the males and females, both of the groups. 10 cases having friends from the same family, from like not only the nuclear family, but from the family member, the big family. And 6 cases are having friends from outside the family. For work, it's a slightly low percentage. 3 cases only got work out of the 81 cases. 2 of them are still working, but 1 quitted work. And all are males, and all of them are from the groups that doesn't have intellectual disability, only ASD, which we consider higher functioning group. For study, 6 cases completed high school, and 3 out of these 6 cases are studying in universities. And again, all of them do not have intellectual disability. They are from the higher functioning group. Here for the sexual interest, we asked them if they have sexual interest or not. And we found that among males, 21%, which is 35% out of the males, showed sexual interest, and females, 5 out of the females, which is 22.7% of the females, showed sexual interest. And from both females and males, the general percentage is 32.1% out of the 81 cases. And we have to say here that most of these cases, the 32.1, are from the group that has both autism spectrum disorder and intellectual disability. We are continuing on the results. Finally, we asked them about marriage. None of the cases was married. And also we add something. None of the cases were engaged or in a romantic relationship, let's say. One of the cases passed away when he was 12 years old, and all the ASD cases that we included in this study, not like in general population in Bahrain, all of the cases, the 81 cases in Bahrain, are still living with their parents. No one is living in institution or residential care. For the study impact, we are expecting that this study will predict which child has good or bad prognostic criteria, and we are expecting that this will help us to modify the rehabilitation programs in Bahrain to suit each child according to the strengths and weakness and evidence-based expectations to answer the questions and the inquiries of the parents at the time of diagnosis of their children. And we also expect that this will help us to educate the parents and teachers on the risk factors and what constitutes a good prognostic sign. For the limitations, our study is retrospective way of collecting data, which depends on the participants' memory. So sometimes they might forget or report improper information. And we did not examine, as I said, we did not examine the child for the presence of intellectual disability. We did not do or perform an IQ test for the children or for adults at this time. And the sample is representative of cases who are attending rehabilitation centers only and in Bahrain only. And this might not be generalizable to the population of OSD in the community. So this is just a summary and a conclusion. I already said them, that the mean age was 22.65 years, 81 cases, employment only 3, intimate relationship 12 out of 81 cases had the long-standing relationship with family members or friends over 1 year, and no one reported marriage. Education 6 out of 81 cases. Intellectual disability presented in 30 out of the 81 cases, 37.04% of our sample. And here, after we divided the two groups into ASD only and ASD plus intellectual disability, we tried to find significant association with the other factors, and we found by chi-square and by logistic regression that there is a significant association with use of medication and the presence of intellectual disability alongside with ASD. And the prevalence of seizures in our sample was 25.9%, which is distributed on both groups, ASD only and ASD plus ID. To conclude, the overall general partitioning was better reported compared to the area reports that we have with similar sample composition. I already said that 1 case died in the follow-up period study, and cases with ASD higher functioning are able to be studied, separately in the next year. We are going to get those with higher functioning to IQ to them and study them with exclusion of the effects of intellectual disability on them. Here are the references. And we want to acknowledge the Bahraini Association for Intellectual Disability and Autism for their cooperation with the research team during the data collection phase, both Ar-Rashad and Al-Wafa centers in Bahrain. Thank you. Do you have any questions?
Thank you very much, Abian, for this nice presentation and very important study that, because we are always meet people and worried about their kids, about their future. So we will take questions later on after the second speaker. Second speaker, we have Ms. Tutik Sukman. She will be talking about perceptions of community rehabilitation team members toward recovery-oriented practices in mental health care. Ms. Tutik is graduated from nursing in year 1999, joined Mohab facility from November 2001, had many years experience dealing with inpatient unit at Al-Amal Hospital, and from 2017 assigned in the community psychiatry department, hospital-based home care service rendering care to mentally ill clients in their own settings. Self-motivated and actively involved in improving quality service in the department, such as organizing and ensuring the schedule plan to help to all patients, maintaining data collections, and has a great teamwork. So, Mr. Tick, please.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Thank you for being with me today. This is my opportunity to be a part of this WPA Thematic Congress. Thanks for everyone. Thanks for the organizer also. Here I would like to present regarding perception of community rehabilitation team members toward recovery-oriented practice in mental health. Let us see the overview of Al-Amal Hospital where I was when I'm working. Al-Amal Psychiatric Hospital is the first specialist mental health hospital in Middle East to obtain international accreditation (GCIA). The hospital also received the international accreditation for occupational health and safety from British Classification Authority. And this is Community Mental Health Team, or we can say CMHT. Community mental health service are multidisciplinary service which provide assessment and evidence-based treatment for patients with suspected or diagnosed moderate to severe mental illnesses who, for reason of complexity, severity, or lack of treatment response, poses barrier in accessing treatment from the hospital or the clinic. So this is the catchment area of our service. We started with Dubai. We start our service in 2016. With one team only. So as now we have many patients who is joining to us. We expanded the service from Dubai with Sharjah to Ajman, and we have some patients who comes from Al Quwain and Ras Al Khaimah also. Community mental health team deliver home care services which known to improve quality, continuity of care. We then let the patient to be lost appointment. Improve adherence of their medication. We given some long-acting injection to improve the adherence, and we keep on checking the medication while doing the home visit service. And our main KPI in the department is reducing and preventing rehospitalization rate. So we strive our best to try to minimize the patient's rehospitalization. From here, this table, we can see that with the blue line, which is rehospitalization. This is rehospitalization rate in year 2022. So out of 92 patients in January, we don't have any patient got admitted. It's like that on February, we don't have any patient got admitted. In March, we have only one. So maximum at the end of the year only, on December, we have 4 patients who got admitted out of 112 patients. And we try our best also to keep the most of patients stable in the community. So this is the rate of like stable patient in the community. We have 99% in the quarter 1. We have 96% in the quarter 2, and we have 99% in the quarter 3 and 96% in quarter 4. CMHT support the recovery of people with mental illness. The combination of expertise and interdisciplinary enable clients to receive more holistic care, which addressing their medical, mental, and social needs. The services are based on care program approach, and the CMHT member includes psychiatrists, physicians, psychologists, social worker, nurses, dietitians, and occupational therapists. This is our objective for this presentation. That to identify current understanding of healthcare professional about the recovery-oriented practice in mental health care, and to discuss common barriers and facilitators for recovery in mental health, and to list the possible solution for implementation recovery-oriented practice in mental health care. The methods is semi-structured interview were conducted with 14 healthcare professionals having extensive years of experience in working with users with serious mental illness as part of the community rehabilitation team, and currently delivering rehabilitation service to 130 service users. Qualitative analysis was done for the data collected, including the recovery self-assessment tool provider version. We use this tool. So in study mentioned, recovery-oriented practice have become a means of promoting user recovery, but do not know much about the concrete means of practicing recovery-orientation for the most vulnerable user with serious mental illness. The strength, needs, abilities, and preference assessment were scheduled for all the client. Vocational rehabilitation and integration into the community was found to be lesser practice. The perception that it's described as cognitive feeling of work associated with voluntary action. So regarding patients with mental illness are often unemployed, less likely to be involved in the close relation among the families, and they tend to have fewer financial resources than their peers. People who have serious mental illness, SMI, are apathetic. They are withdrawn and socially isolated. And stigma experienced by those who are mentally ill has been linked to self-esteem. Block to recovery of individuals with serious mental illness can be external or internal factors that hinder a person's ability to achieve their recovery goals. Current understanding of healthcare professional about recovery-oriented practice, this is the result from our discussion, that 70% of staff explain recovery to be reduction or absence of clinical sign and symptom from mental illness. And staff had lesser hope as expectation for users' recovery. This could be due to the longer duration of their illness and multiple relapses. Also, the most important is that there is no family support. While the adopted program scored significantly higher on empowering users to engage in their recovery process and respecting their decision for overall care. So on the other side, we can see that this is the clinical recovery vs personal recovery. So we try to find that now we need to look to the personal recovery. Clinical recovery is like the traditional method of this one approach, which just seeing the patient by their symptoms, by their sign, by their deficit. Where we need to look to the recovery and rehabilitation is we need to see a patient's strength and empowerment, what they can be a function in their community. So this is some of our activities in our service, that we are seeing the patient by multidisciplinary team. We see their bio, psycho, and social also. This is, we check the blood sugar, monitoring, blood collection, administration of depot injection. We have the health education to the patient. We ensure their medication compliance. Then the case was discussed by a multidisciplinary team, and this is some methods which we use to improve the medication adherence so that the relapses in the community will be much reduced. So the patient who is having poor adherence, we explain, we give the instruction how to be adherence to their treatment. And the recovery, one of the most accepted theoretical framework to understand personal recovery is CHIME, C-H-I-M-E, a compilation of 5 interrelated recovery process connectedness, hope, and optimism about the future, identity, meaning in life, and empowerment. This is, we are seeing the patient as a biopsychosocial model. This is it is generally accepted that the illness and health are result of interaction between biological, psychological, and social factor. From biology side, about their physical health, genetic vulnerable, there is drug effect, for example. In the social aspect, peers, family circumstance, family relationship. From the psychological aspect, physical health, coping skills, social skill, family relationship, self-esteem, and mental health. So here regarding psychiatric rehabilitation, rehabilitation is a process of helping the person return to highest possible level of functioning. Psychiatric rehabilitation is aimed at long recovery, maximization of self-sufficiency. Psychiatric rehabilitation uses a person-centered that differs from the traditional medical model of care. Psychiatric rehabilitation grew out of the need to create opportunities for people diagnosed with serious mental illness to live, learn, and work in their own communities. So what is the barrier to a psychiatric rehabilitation after the discussion with the members? Here, barrier to a psychiatric rehabilitation. We have stigma of mental illness and deficit model of treatment, nature of severe mental illness, lack of motivation and acceptance for changes, poor caregiver involvement and engagement, which really this is a big barrier for us, medication adherence and lack of intersectoral collaboration. Then the facilitators towards psychiatric rehabilitation, we found that comprehensive care and multidisciplinary team is helping towards the psychiatric rehabilitation. Innovation, use of technology, which is very important to the psychiatric patient, which require long-term treatment. Especially during COVID, we able to do telepsychiatric, which improve the medication adherence and service continuation of service to the patient. Patient-centered care and early intervention, collaboration from different agencies, cultural competencies, social support or caregiver support, which we have also conducted in our service. So this is the key principle of recovery-oriented practice, include hope, person-centeredness, empowerment, holistic care, and peer support. This principle emphasizes the importance of collaboration and partnership between individuals with lived experience of mental illness, mental health professionals, and other stakeholders. Here, regarding the personal recovery, we try step forwards in collecting some data, what we can do better for our client. That is, we try to get the data of number of employment status in the client within who is under community mental health team. We found that currently a patient who is employed, we have 12 users out of 130 patients. It's equal to 9% in our service. And the patient who employed in the past, we have 18%, that is 23 users. And the patient with special talents, we have 6 users, 8%. So we try to find the strength of our client in the community. And the client who requires job, we find 12 users or 9%. This is some our users product. We try to encourage them, although they are in the community, they don't just come, take the medication and sleep and do nothing. So once they have the strength, like having good skill in art, having this some specific talent, we have actor, we have this one, the bouquet is done by crochet, this one. It's very nice, this one. So we encourage them to keep continue so that they will be engaged, that it will be improving their self-esteem, which is very good for the recovery journey. So this is with some activities also which promote our the rehabilitation to the patient, which is we said like patient-led activity. So the patient will lead the healthcare provider in doing some workshop. This is doing painting, art. So we participate with them. So the result is what's possible solution for the implementation recovery-oriented practice in mental health care. We've checked from some studies, literature review done in Indonesia. This is my original place. On the principle of the recovery-oriented mental health service from 5 different countries reveals 7 recovery principles, including cultivating positive hope, establishing partnership and collaboration, ensuring organizational commitment and evaluation, recognizing the consumer's right, focusing on person-centeredness and empowerment, recognizing an individual's uniqueness and social context, and facilitating social support. So these 7 principles are not independent, rather they are interrelated and overlap each other. This is a review of guidelines from 5 different countries for developing a protocol which to be implemented in Yogyakarta, Indonesia. So another qualitative study done in Taiwan on the professional perspectives on providing recovery-oriented service suggested factors like family collaboration, anti-stigma efforts, and change in policy and attitudes as critical to be successful implementation and delivery of recovery-oriented service. This is study from professional perspective on providing recovery-oriented service in Taiwan, a qualitative study, volume 21, article number 154, 2021. So in conclusion, recovery-oriented practice is an important and effective approach to mental health care that recognizes the importance of persons' perspective and experience in their own recovery journey. It emphasizes collaboration, empowerment, and holistic care, and has been shown to lead to positive outcome for individuals with mental illness. This requires nationwide policy changes to be implemented for resource allocation, digitalization of mental health to minimize gaps, intersectoral collaboration, and there are cross pressure between different interests. Research has shown that recovery-oriented practice can lead to positive outcome for individuals with mental illness, including improved quality of life, increased social functioning, and reduced hospitalization rates. It has also been found to be a cost-effective approach to the mental health care. So this is the references, and this is our team members in Al-Amal Hospital, Community Psychiatric Department. The so-called recovery is something that you have to work on every single day. And it's something that doesn't get a day off. Thank you for the listening, and assalam.
Thank you very much, Mr. Tuk, for this comprehensive and important talk. Please stay here, so Dr. Abian and Mr. Tuk. And the floor is open for any question. Yes, Doctor?
Okay, Dr. Ahmed Al-Ansari from Bahrain. Thank you, Mr. Abian, for much needed study in the area. I think you presented the data that is probably is the only data available for follow-up studies in the region for ASD. So congratulations for you. I have a question, which is maybe, I don't know if he has an answer or not. You're a medical student, you're a 6-year medical student. You did research in physical medicine, and this is your psychiatry research as well. So how can you tell us, from being a medical student, what is the perspective for psychiatry research? How it is different from physical research, the way you see it? I want you to talk about your experience doing two types of research.
Yeah, you mean the difference between the clinical research and psychiatric research? Yes, okay. So the main difference that in the clinical field, things are more depending on lab results, on physical examination, and on seeing that disease-based thing. And in psychiatry, it could be more toward the patient's life. It's more about the criteria-based diagnosis. We are covering like the whole life of the patient instead of just getting the laboratory investigations that we have to. So this is the main difference that I can see, and hope this answer.
Yeah, so you're saying that in psychiatry you take like the holistic approach. You take the individual, not the sickness
the individual
itself.
as a human being.
Yeah. Thank you.
More than a laboratory result.
Please.
Thank you, speakers. It was very nice presentations. I have one question to Dick. When you are showing the data for 2022, it was showing that in the last year, I think the readmission, the rate was 4 instead of, throughout the year it was very low. And at the end of the year, I think it was showing 4 readmissions. Am I correct?
Yes.
So what could be the reason, or as a community health team, could you evaluate the reason for increasing such a number in that month, and what was your actions in future to prevent such a hospitalization?
Yeah, thank you very much, Ms. Bina, about the question. It's very good question. Yeah, we also like really like once of our client got admitted, we feel like our heart is broken. Like we try to make it possible like zero in the month of like no admission rate in the month. So we also like really got surprised with this increased number of the readmission in the end of the year. So then we take some action. We try to see what is the possible of the reason of patient got admitted, and we find that some of the patients which we are there is new cases which still like unstable in their mental status, and also like we also find some other which is it is not confirmed, but we also find some other thing, maybe the training of the patient which the staff which require. For especially we have many patients who is on long-acting injection. So we collaborate with the company of the medication, and we done the training for proper administration of the injection, which it is also can be find that usually the drug regimen it will be solid and it will not be doubtful about the competency. So with the administration, we need like more practice or more correct administration, like one long acting which required the shaking of this one, so that the medication will be really mixed, not only like the shaking if not correct, then it will be like the medication it will keep in one place and only only solution which we give to the patient, like it is placebo we can say. So we also made this research, so we done the training to the community team members, and alhamdulillah with that one, so we can manage the like we see the next one is like the patient readmission is got lesser. So this is some action which we are doing, and we also monitor the compliance of the medication and see other aspects, maybe socialization. As we are, what we are seeing that we need to see like when patient relapse is not only from their medical side. We need to see also maybe from the social aspect which happen to the patient. Maybe there's life changes in the patient. So we need to deal with the life situation with their social situation, what to overcome to that one. So this is what we have done.
Thank you so much, Doctor. Thank you very much.
Any other
One more question.
Yes.
Thank you, speakers, for the very pleasant presentation. Question is going to Tutik. You were mentioning about rehabilitation. So my question is, what is block to recovery rehabilitation, and why is it important? Thank you.
Thank you. Yeah, this is also another good question. What is block towards recovery? We know that the block to recovery is something which blocking the recovery, means something which what the recovery cannot happen. Yeah. So actually block of recovery, there is external and internal, like what I have seen shown in the slides. So what is the external blocks which usually happen, like this poor of family support, then lack of collaboration, lack of interaction with the recovery process. Then there is maybe barrier that no one is sending the patient to the hospital, or maybe because of far location, then they cannot access to the facility. So this is external factor blocks which usually really blocking the recovery process to patient. Then internal blocks which is came within the patient. Maybe patient doesn't have motivation. Then family they don't want like it is stigma. The patient has to be the mental illness has to be at home and they don't want to do anything. So mostly like that. Is that okay?
Yes. Okay.
Thank you, Dr. Riyad. Thank you for the presenters. I have a question for Mr. Bian about in the statistics there was, you mentioned in the sample 51% they use medications.
Yes.
Yes, and
51%.
They use both medications or either?
They use like both or either one.
Yeah, and 42 were on both.
No, like 51.
Okay.
Like 42 out of the 81 cases.
Okay.
They
Okay.
are using either antipsychotic or anti-epileptic or both.
So, okay. So not mentioning like
Yes, we did not separate it.
okay. And what about the sexual hyperactivity
Sexual interest.
interest? Is there like compared to the use of medications?
Between the sexual interest and using
Yeah, like
medication.
from those patients, so increasing the sexual interest.
Yeah, we did not find a significant relation.
It's not relation. There's no. Okay, that's what I wanted to check.
Yes, we only saw that those with sexual interest are from the group that has both intellectual disability and ASD. This was significant.
Okay.
But between the medication.
Yeah, but I mean, like they haven't
this
touched.
wasn't significant.
Okay. Okay. Just want to check about that. Thank you.
Thank you. Another question? Last question from me to, we know it's autism is a long life disorder, and the transition from childhood to autism, actually this question that most of the parents are concerned. Do you notice, apart from the medical comorbidities that epilepsy and other issues, what
Yes.
other mental comorbidities?
Yeah, actually, we tried to ask them if the children has any other mental or medical comorbidities. We did not mention it because it was not one of our objectives actually, or one of our main focus. We focused on the intimate relationships and employment here. But 3 out of the 81 cases were diagnosed also with ADHD, and 3 also others have psychosis. So we did not mention this because it was not like from like the main objectives or the aim that we have, and also because our sample is very low, it's about 81 out of the total of like 120 that are attending to the centers that we have here. And we saw that this will not like give us statistical significance to be studied at this like size of research. That's why.
And regarding the 2 patients who are working, what kind of job they are doing?
3 of them actually working. One of them was working with his mother at a private company, and 2 of them I don't really remember what their jobs were, but simple jobs,
Yeah, because you know the
very simple jobs.
yeah.
Yes, one of them was actually working at a company in Bahrain at a factory, but it was also a very simple job, like for doing some
repetitive job. Mostly they are successful in repetitive kind of job
That's it.
that doesn't require
But the
analysis.
jobs were not really were not complicated jobs.
Yeah. Thank you very much. Any other question?
Yes, Dr. Hussein Shahuri from Bahrain. I have a question for you about the role of physician and occupational therapist in your team. What I understood, we have community team in Bahrain, but it does not involve either a physician or occupational therapist. What I saw here, or I noticed that even the patient who were involved in some sort of rehabilitation activity was brought to the institute itself, the example you gave. But are you doing something at home for them? I mean the occupational therapist?
Thank you, doctor, for the question. Yeah, in our community team members, physician, what they are doing is like to check the medical side, any metabolic screening happen. And recently also we have a clinic which we are planning to name it as integrated mental health, which is a combination of psychiatrist, physician, and dietitian in the clinic, so that we are checking the patient overall. Then regarding occupational therapist, actually this is still like we try to like for the occupational therapist, usually like we want the occupational therapist to check the safety of like for the initial home visit. Usually we want the to check. We need the safety of the staff. Also, we need the safety of the patient. So during the home visit, we want initial home visit that the occupational therapist to check the area if it is really safe for the patient of anything which can be modified, or if we assess the patient with the strength which require occupational therapist to do the intervention in that, so this will be applied for the occupational therapist.
Yes. You have a question? Yeah, last question, because we are running time.
To Dr. Abia. You mentioned that the data collection mainly, you have mentioned that ESD, you were asking the mothers, isn't it, in your studies? The data were collected when the patient's mothers, right?
You mean about intellectual disability?
No, autism.
Yeah.
So,
What was your mothers?
mothers. So regarding the sexuality, this also you were asking to the mothers about the patient's sexuality, or you were asking directly to the patients during your studies?
To the mothers, actually.
To the mothers. Okay. So in case if mother is not the one carrying the patients,
Yes.
so you are approaching whom? If
We are switching to the main caretaker, either
The-
the father or any family member who is responsible for that individual.
okay,
This is what we do.
okay, thank you so much.
Okay, so we come to the end of our session. Thank you very much, Mr. Abian. Thank you, Mr. Tuk.
Good evening, everybody. Shall we make a start? My name is Dr. Ala Hawil. I'm a consultant psychiatrist in the American Center for Psychiatry and Neurology, Abu Dhabi, and I have the honor today to present three speakers. Our first speaker is Dr. Rajesh Nagpal. I hope that I'm pronouncing his name correctly. Dr. Rajesh Nagpal completed his MBBS in 1982, same year as mine. Postgraduated from the Postgraduate Institute of Medical Education and Research in Chandigarh in 1987. He is a trustee, Diva Foundation Director, Behavior and Neuroscience Academy of India, and past President, Indian Association of Private Psychiatry and Indian Association of Biological Psychiatry. He is a consultant psychiatrist and has a private clinic in New Delhi. Please have your hands together for Dr. Rajesh Nagpal.
Thank you.
He's going to talk to us today about running a psychiatric rehabilitation center, weaknesses or pitfalls.
Good evening, and thank you very much for this opportunity. I will be talking about running a psychiatric rehab center, weaknesses or pitfalls. My disclosures: none. Qualification: I ran several rehab centers, always incurred economic losses running these rehab centers. Learning objectives are smarter or economic viable rehab models. We require replicable models, and we require RCTs pan-world, because this is a global issue today. In India, vast majority of patients do not have access to any meaningful psychosocial intervention. A full functional integrated rehab service is a distant dream. So how do we define the challenge in the Indian context? India is home to 1.4 billion people, or 140 crores. Persons with mental illness, 10%, that's about 14 crores. SMI is 1.5 crores. Rural population, 60-65%, 75%. Urban, about 25%. 70% of our people are either in semi-urban areas or rural areas. And almost 80% psychiatric facilities are in the urban areas. So that's the first distortion. Almost half of the SMIs need psychosocial rehabilitation, roughly 70 lakhs. This excludes intellectual disabilities and substance abuse. Of this, 70% stays in villages, 50 lakhs, and the treatment gap is huge, practically 90%. But the glimmer of hope is that per capita income is increasing significantly. Out-of-pocket expenses for health have reduced. Insurance has now begun to cover mental health. Government-sponsored world's biggest healthcare scheme, Ayushman Bharat, is a super hit. But rehabilitation is still paid from private pockets, unlike in Abu Dhabi. The first question that we have for ourselves is that do mental health professionals or regulators, that is sponsors of the government, desire a full service rehab? Conflict in treatment approach sharpens during rehabilitation. Biological and psychological treatments focus on deficits at the individual level, our symptoms and disabilities, wide scales. Social interventions try to address local inequalities and barriers in order to improve access for mentally ill to ordinary housing, meaningful employment, and leisure. Social care is not the business of healthcare, apparently. The history of healthcare does tell us that social care is often underfunded. There's excessive emphasis on the health model of individual deficits, which is a slippery slope to institution by way of therapeutic nihilism. Are we not going back full circle from de-installation to poor community care to again private asylums or private installation? Do we believe that outcome of common mental illnesses or SMIs can improve by biological approach alone? A resounding no. Rehab services, now more biological than biopsychosocial, need to acknowledge the central role of social interventions. Social interventions improve the functional outcome that matter to patients and caregivers. Theoretically, access to housing, occupation and leisure facilities, and the support of family and friends can enhance functional outcomes. It is patently unfair to prioritize individual change. A social perspective says that cause and maintenance of mental problems lie outside an individual. For example, stigma, discrimination, childhood trauma, to name a few. And it is imperative that external social conditions change. This entails working with different vested interests and agendas. What may be good for elevating mental health problems may run counter to how a society responds to inequality. Currently in India, we are seized with the issue of the lesbians, gays, transgenders, intersex, and the issues before them. And it's a huge kind of conundrum which is troubling us. It is patently unfair that more attention and resources given to interventions aimed at changing the individual, even if the obvious defect lies externally in abusive relationships and the discrimination or structural failings of society in terms of economic inequality. Halfway homes, supported accommodation, community services are not subject to debate and discussion. They, of course, merit a short note during our PG training. Psychopharmacological management of treatment of schizophrenia is the evergreen flavor. Emphasis only on acute care and outpatient care. This segment of need for patients, social care, is completely sidelined. In the Indian context, unreplicable role models in the public sector. Organized rehab services with adequate budgeting and human resources are scarce in government and NGO services. In the public health sector, no real economic audits available. NGO sector, real losses. Replicable initiatives are very few. Primary reason is no insurance cover for rehab in spite of the Mental Health Act clause. The larger goal, as we know, is rehab framed within a model of personal recovery. The target of intervention is to boost hope and help individuals find a meaning in life, living well regardless of enduring symptoms. The realistic goal is the patient can be contained within the premises and taught or retaught basic life skills. On discharge, he is manageable at home with some ability to look after his own needs. Now I'll come to some India-specific issues. Types of PSR or psychosocial rehabs are short to mid-term facilities, long stay, geriatric homes, child adolescent care, deer centers, halfway homes and daycare centers. I'll touch a few. But some uniform constraints exist in all these sectors. There is a serious lack of human resources. Trained personnel, occupational therapists, psychiatric social workers migrate to greener pastures in UK, Dubai, Abu Dhabi, US, etc. Regulatory bodies with sole aim of being a stumbling block leads to disillusionment among younger professionals. Evolving return on investment models make corporates hesitant to step in. And the National Drug Psychotropic Act is also a big deterrent. Hospital initiatives. The mental asylums were re-christened centers of excellence, and thanks to intervention of the National Human Rights Commission, simple occupational activities changed to income generation activities. And the nurses gave way to occupational therapists. Simple occupational activities are now being replaced by income generation activities. But the catchment area is very narrow. Much of India exists in the rural zone, as I said earlier, where hospital initiatives hardly touch. The opportunity is a reduction in hospital stay early discharge is the norm now. Expansion of the district mental health program to support the patient in a community is a distinct doable. In the NGO sector, notable initiatives include SCARF Chennai, Medical Pastoral Association Bangalore, Richmond Foundation, the Deva Trust Varanasi. These are governed by the Mental Health Care Act 2017, and this is the single biggest impediment faced by the private sector who want to expand in the psychosocial rehab sector. So we propose a case for public interest litigation before Supreme Court that put us under Persons with Disabilities Act and not under the MHCA. Daycare centers. About 25 daycare centers spread across few states like Maharashtra, Karnataka, Kerala, offer day-to-day care services, including income generation training. The weaknesses are lack of certification of training which prevents employment and no government financial support. There are noticeable endeavors but not replicable. For example, extension of the district mental health program in Malappuram, Kerala, and rural initiatives in Thrissur and Silchar. Long stay facilities. Deva Trust, Cadamums, very few facilities offer long stay. Only few can afford and there's no viable financial model which exists. May ultimately end up as private asylums. Insurance sector, reverse mortgaging and other initiatives are solely required to invigorate this sector. Home for the homeless. The European concept of housing first is an unknown concept on Asian shores. Mentally ill homeless individuals are intrinsically very vulnerable. Some notable initiatives self-funded or through local families exist in Kerala, Banyan, in Chennai, and Vatvanis in Karjat. Some training initiatives by the Nimads group for Kerala has occurred. This requires state government, some kind of nurturing by state governments. Deva Trust works with UP government in this sector for 4 years, but the project fell through because of lack of structured public-private partnership. Opportunity is public-private partnership for this sector is sorely needed. Caregivers pitch in. Notable initiatives like Asha Deep in Tamil Nadu, Asha in Assam, in Schizophrenia Family Federation of India, and Schizophrenia Awareness Association Maharashtra are user initiatives. These are ground level initiatives which need, and the money comes from the family themselves, which need care, nurturing, wide recognition and financial support. PSR initiatives in drug users. Ministry of Social Justice and Empowerment would fund initiatives for treatment and rehab of drug addicts. The Mental Health Care Act cleared the pitch. The Nasha Mukti Kendras or DL centers offer containment services and rudimentary 12-step A programs. Majority of the programs are dual diagnosis, majority of the patients are dual diagnosis, but the only effective strategy is containment. These are very pocket friendly, but violate every rule in the ethical book. Opportunity. A looser regulation by the state mental authority which sets easier norms for mental establishments housing drug addiction patients for long-term care. Therapeutic evidence-based strategies beyond AANA, like DBT, motivation enhancement, need to be strategized and bought in. Creating trained personnel is the bigger channel here, is the bigger challenge here. In conclusion, younger professionals need evidence that social interventions improve outcome. Right now, all younger people today, younger psychiatrists feel that biological alone is the way to recovery. Young professionals need exposure in community programs. They need to refine outcomes of functional recovery. Expose the preposterous claim that remission can occur without psychosocial component. Example, if you look at the drug trials of varenicline in smoking, the phase 3 trial had one short CBT program which was never mentioned in the entire data. It took us great effort to take out raw data. So it is primarily a drug used for stopping smoking, and the psychosocial kind of intervention did not merit a single mention. Dr. Afzal Javed has come just in time. So what's the role of the World Psychiatric Association? Compile pan-global data on outcome of psychosocial interventions, use AI for effective dissemination of information showcasing the latest data sets, develop minimalistic guidelines for broad phenotypes, example, impulsivity, compulsivity, aggression, and attention, and not the illnesses like schizophrenia, bipolar, organize debates challenging the discard of biopsychosocial model, and invigorate the earlier career psychiatrist, institute rich cash awards for innovative programs for psychosocial delivery of mental health care. I thank you for your attention.
Agree on having the discussion following each presentation, or would you prefer the discussion to be after the 3 sessions? So what would you prefer? Yeah, okay. I mean, thank you very much, Dr. Rajesh, for your quite important presentation. Can you just have a seat, please, here? And I believe rehabilitation in psychiatry has always been a major issue. And we all are aware of the history when the deinstitutionalization started and we moved into the community care. Unfortunately, huge percentage of our discharged patients, they ended up basically in the acute care, and some of them ended up in forensic secure units. Some of them deteriorated, and basically rehabilitation is no longer there. If I take actually the example of the UK, for example, the outcome has always been huge increase in the number of forensic units, and basically inpatient units attached to general hospitals started to do part of the job, but usually there's an issue about rehabilitation. And rehabilitation is mostly funded in special hospitals like St. Andrew's Hospital, the hospital I used to work in, and usually funded by the government, and it costs a lot of money. So maybe I start with asking Dr. Rajesh, basically, I mean, with the huge population in India and following the model of deinstitutionalization, you did mention a number of challenges, and it's all about financing these institutions, and we end up only giving care to acute patients, and we don't care about the actual recovery. Give schizophrenia as an example. Acute care is the easy part of it, but the rehab and long-term care can be a challenge. So how about schizophrenia rehab management in your location?
It is run primarily by the NGO sector. The problem, sir, is that the money comes from private pockets. A family of 6 has one individual who has schizophrenia, and that becomes a major drain on the expenses. There is a study done in India that if a person suffers schizophrenia, a middle class family becomes low middle class in 1 year, and very low middle class in 2 years. So unless the WPA devises techniques by which they convince the government of India to fund these programs, nothing will happen. Because private pockets always has a limitation in this regard.
Okay, I mean, we have a question here, then I will ask another question. Can I have a help here, please?
Okay, if you allow me, some of your recommendations are very general and they are from the literature. I would like to hear from you a recommendation and solution that comes from you Indian people, how you would like to see, how you would like your situation to improve. Do you understand what I'm saying?
Yes.
Okay.
So India has a good infrastructure, a large mental professional base, and a solid middle class population to understand the entire problem. The biggest impediment is regulation. I will give you a small example which I quoted even yesterday. In the state of Bihar, there is a place called Koilwar, which is of 260 acres property. It is basically a mental health rehabilitation center which got derelict for the last 40 years post-independence. Today, 1/3 of that 260 acres is covered by the paramilitary range who are camping there. The rest of the place, including beds, ECT machines, neuromodulation, lies vacant. One professor of psychiatry from Patna Medical College comes and runs that place once a week with a team of 3 people. When we approached the Bihar government that we in the private sector will run the entire place with the same money that you have allocation, they couldn't stand the thought of it. The offer was thrown in the trash basket. So the biggest problem we have is regulation, who look on private sector as mercenary, and that is the problem. We can manage our own resources, but we should be given permission to do so. That's the one example from, it's a very local context, but it's important.
Yes, there's a question here, please. Dr. Javed.
Well, thank you very much, Havil. Thanks, Rajesh. I'm sorry I was a bit late. I was in another session. My personal comments are that we have to make a conceptual change in rehabilitation for mentally ill. First of all, we should not say that who needs rehabilitation. We should say who doesn't need rehabilitation in mentally ill. That is number one. And number two, we have to find out that what are going to be the outcome of rehabilitation when we are offering this, especially in low and middle income countries. We recently published a paper showing how we can empower, financially empower mentally ill so that they can become productive citizens of the society. This is probably what we need to do, especially in our countries where we have got no support from the government, that we should try to make these people financially empowered by setting up some programs, by initiating some small businesses. Wherever you keep them, wherever you want to treat them, ultimate problem would be the financial. Because in many countries, families cannot afford even the general basic medicines which are needed for follow-up. So I think this is probably a major pitfall that we psychiatrists or mental health professionals have not been agreeing how to approach the rehabilitation in 21st century.
Thank you, sir.
Thank you, Dr. Javed. Any more points to raise? Here, this doctor here, please.
Thanks a lot, Doctor. I think in going with Dr. Jaweed's comment, we used to teach the medical students that the outcome for schizophrenia, I'm not talking about severe mental illness or treatment resistant, the outcome in general, in developing countries is better than the developed country. Part of it because the demand from the schizophrenic patient is different. So in India, for example, especially in rural area, maybe he will be more accepted. He may get even chance to get married and his wife will take care of him. He can work in a simple job. So he can have a more meaningful life than somebody with the same maybe severity in the Western country. But I agree with you totally what the struggle is with the severe mental illness and treatment resistant because they are really challenging everywhere. Even in the Western countries, they were talking about closing the institute permanent, but this was not successful till now. With all the amount of money they spend and community services. Thank you.
Sir, this was a matter of great debates regarding schizophrenia. The IPSC study showed very clearly that the outcome in developing countries was definitely better than the developed countries. But came the argument that these patients would ultimately go to menial jobs, so the outcome wasn't actually measured properly. But today we have revisited the same data. Data came in from actually Agra. And now we are wondering that maybe the family system of the Middle East or of the Asian countries, which actually bring a good prognosis. And we in Asia should now lead the way to the Western society, tell them the importance of family. Because we in our own country also, our families are also breaking up completely now, from large families to nuclear families and singles today. So this kind of learning is very important. It should be part of the debate and the discussion to improve prognosis in schizophrenia.
I think I totally kind of reflect on that by giving UAE as an example. I work in Abu Dhabi for the last 15 years. I used to work in the UK for 12 years. I've seen a lot of differences. And to be honest, although we think that the problem would be about the resources, but it's not about the resources. It's about basically the planning, the initiative from the government. I have to say that we struggle a lot about post-discharge rehabilitation for people with major mental illness like bipolar and schizophrenia. In Abu Dhabi, for example, there are a lot of private centers with an excellent service when it comes to psychotherapy, if you deal with a borderline personality, depression and anxiety. But when it comes to major mental illness, we don't have a day center except in Sheikh Khalifa Medical City. The government sector is very small. We don't have, for example, drop-in centers. We don't have a facility for rehab of people, mainstream schizophrenia, or even forensic cases, whatever. And to be honest, I mean, the policy makers and the initiative seems like it's going to take more time. So the resources, I do believe is not the issue here, but the issue is about the planning and prioritizing for people with major mental illness. Okay, so any more points to add here? Right. Okay, so we will conclude here, and we have to thank again Dr. Rajesh for the good work and good presentation. Thank you very much. Our next speaker is Professor Gandugarti Prasad Rao. I hope that I'm pronouncing it correctly. I have few information about Professor Rao. He's a life fellow of the World Psychiatric Association, past president, Indian Psychiatric Society, and the past president, Indian Association of Biological Psychiatry. He's the past secretary of education and training in the AFPA, current president, Asia Federation Psychiatry. And he's going to talk to us about a quite important and interesting subject, the newer horizons of Alzheimer dementia by biomarkers. So have your hands together for Professor Prasad Rao.
Thank you. I am Prasad Rao. Prasad Rao, yeah. Thank you for the introduction. And we hugely thank this Congress for giving us the opportunities. I would start greetings from our Asha Hospital, Hyderabad. This has probably one of the largest rehab with almost 350 beds right now, one separately for men and women. But my topic today is to look, a new look on the biomarkers, the current status in Alzheimer's disease. I have no conflicts to declare, but I would say I've been working in Alzheimer's for the last 10 years. I'm just finishing my PhD in the neuroimaging. So that's the reason why I'm talking on Alzheimer's. Dementia. I think it's quite easy to diagnose once a patient comes with a memory deficit. And for all the psychiatrists sitting here, in fact, they come much more for the behavioral and psychological components of the dementia for which they present to us. Formally, for any dementia to be assessed, I think we use the psychological test. And I'm going to show you the same patient which I've been following for the few years. As you can see very clearly, though the pointer might not show, each 6 months, the progression where the hippocampus size is totally narrowing and the ventricular size is actually, you can see. So the diagnosis of dementia is usually too late. Even by the time he comes to us, it is late. And what is happening around the world and some parts of our area, the Asia Pacific, is to actually identify and do the biomarker study, especially. And I'm going to present in the next 20-25 minutes, I'm going to tell you the story, what's happening around the world and part of our countries too. As you can see in this slide, the most important areas is that each dementia patient is different, depends on the areas he's getting affected. It can be frontotemporal, it can be medial frontal, the cognitive controls, the default mode, and the implicit circuits. And in most of the studies in our country, as you can see, the large blue is the Alzheimer's alone. But in our country, another 30% actually have vascular dementia associated with Alzheimer's. So if you really take around 70-75% of our patients do have Alzheimer's, either alone or with vascular. And other dementias, Lewy body with Alzheimer's, or alcoholic dementias are quite minority, as we have seen. The most important component which I would try to stress is we probably need to identify the cognitively impairing state of some people. And today's research actually talks that our screening of the biomarkers, which I'm going to cover in the next few minutes, should actually start way back around 50s or even early 50s, especially whenever there's a family history. In fact, as the curve comes down, as you can see the red line and green line turning down, most people come at that stage where the course can be variable at that point of time. We also probably have to acknowledge that pharmacologically, except donepezil, rivastigmine, and probably galantamine and memantine, the only two groups of molecules which are available, more often than not, we are treating them symptomatically for the behavioral and psychological symptoms. Suffice for me to say that the mild cognitive impairment, if we recognize at that point of time by using variety of biomarkers, we know it can halt by 10% this slow progression, and we can actually delay the development of dementia or give a quality life. So with this background, I would just start with the story that majority in our country, the recognition of long preclinical phase of Alzheimer's disease is quite slow, as you can see in this picture. And what Alzheimer's has identified more than 110 years back still continue to be the pathological cause, but we really don't know what causes it. But we really do know, and from a biomarkers point of view, diabetes mellitus uncontrolled, high blood pressure, obesity, and high cholesterol are the most common contributory factors. They are not the biomarkers of Alzheimer's. And insulin resistance, oxidative cell damage, and fat cell activity are probably etiopathogenetic in the overall development of dementia. I would now focus on the usage of the diagnosis of biomarkers. In this presentation, I'm not going to touch too much on the memory testing, though that is probably the hallmark of a diagnosis to be made. But I would touch on the current available testing of the genes. We'll start with the genetics. How do I find a vulnerable people? Among the genes, for example, is Alzheimer's hereditary is a common question asked once a patient develops, and all the family is very much worried about that. And what is the cause of Alzheimer's? There are two groups. One is a sporadic group, and one, for example, in sporadic group, it occurs in 15 to 25% of the family. So that's what we are going to tell the patients, as you can see in this my state. I can show and tell my patients and their families, as the age progresses, as you can see here, the risk of Alzheimer's is more, and the rule of the thumb, the risk actually increases as the age progresses. But is there a genetic testing advisable, is the question asked. In general, no. But I'm going to give you the evidence of the only biomarkers which commonly we tested. As we know, the single major genes are probably contributory in most of the sporadic cases. Complex inheritance, just like in any other psychiatric genetics. It's unknown in most cases. And when you really ask, yes, with a big no, especially in a family history, as you can see here. If you have multiple family members, probably this is the group which we should start testing much early. And the difference here, as you can see in this diagram, about 20-25% of the cases, there might be some hint of the family history. And sporadic cases differ that they occur much late, whereas familial cases occur much early in the onset, as you can see. Any guesses? The only testing which probably we can recommend, and which we have done in my research study, is an ApoE genotyping. Remember, it's not all alleles. The only allele which is being associated, as you can see, is the ApoE4 gene. And if this is positive, we only tell them that there is a high predictability, that a possibility of development. So we might have to watch you much more closely. So this is probably the one of the genes. But over the period, I think we started recognizing the complexity of the genetics, the complex inheritance which happens. In fact, these are the 5 genes which are putatively suggestible genetic testing. And we are now developing a small battery of tests for this memory within our center. We are using the presenilin PS2, presenilin 1, ApoE4, amyloid precursor protein, and the gene in the 12. Remember, this is only suggestible, and the cost of this is bit high, almost $900 per patient or per individual. So this probably would recommend, and that's where the genetic testing stops as a biomarker. We have only few genomes which can be tested. The cost is this much for the family, especially when there is a multiple family members. And there are also other considerations, for example, the informed consent. Here, we are only giving a message that you have a high probability. We can't really say that you will develop. And this would definitely affect the whole family. Already there are multiple family members who are affected. But there probably would be a time in the next 10, 15 years where the affected family members, less than 60, might be tested for the Alzheimer's, and that might take a decade and a half. Now I'll come to the most important biomarkers which have developed over the last 2 decades. That is the neuroimaging biomarkers. CT scan does not pick up, but neuroimaging tests by MRI, as you can see, this is again the same of my patient whom I followed over the period. You can see, and what we are going to test is the progression and correlate that with the neuropsychological testing. And as you can see, you progressively find, there are 2 groups which we find, and normally, this is for example, thanks to the artificial intelligence and thanks to usage of software, how to do a diagnosis as a biomarker. It's simple MRI doesn't help. A 3 Tesla machine is needed, and T1, T2 images, and using a software of dementia protocol, we actually calculate the FASICA score, mean temporal atrophy score, hippocampus atrophy score, CADAM, which is parietal lobe score, and general cognitive atrophy score. You would get very surprising results in the very early stage, and this is essentially helpful for the diagnosis surely. But if you keep on doing repeated images, we know how the disease is progressing or whether they are how. So can we rely exclusively on MRI? To some extent for the diagnosis, yes, but we need to add MRI with the psychological testing. Then, over the last decade and a half, quite a lot, or 2 decades I would say, the neuroimaging markers further on, starting with the FDG PET scan. But FDG PET scan again confirms already set in dementia only. As you can see in the top, this is an Alzheimer's when compared to frontotemporal, and you clearly find a lot of difference between the 2 images. And over the period of time, I think we started now identifying the real biomarkers. The first among them is the Pittsburgh compound, or the one which was approved by the US FDA, and that combined with the cognitive testing can actually be a good biomarker to start with. Because right now, these kind of markers have established over a period of time how to prognosticate a patient and how to diagnose quite early. The cost in our country for a simple FDG is about $350, which is probably because most of the times our patients pay for it. Now we are becoming more and more specific to relook into the disease pathology using this technology. And as I told, the neurofibrillary tangles, which is a tau protein or amyloid plaques of a beta amyloid. Now the technology is now, as the biomarker started, and right now we have at least 8 to 10 biomarkers which can pick up both amyloid and tau imaging. Now we talk about these 2 imaging as a good biomarkers. The specificity definitely has improved. Now I'll start showing a few, and this is probably the pictures which we just have in big metros in our country. I think this has to catch up. Right now the technology is the T3 MRI or the Tesla 3 MRI with the neuropsychological test, but I think we have started using across the country, especially the PET scans being available and using the Pittsburgh compound which is available. This is probably the further advances over the Pittsburgh compound, the amyloid. You can see the difference of one of the patient, this is borrowed from it. I have another patient, how he got converted in 5 to 6 years. Right now, we can actually diagnose very early, but more important, using this technology, amyloid is being used much more than the tau imaging. We can actually see the course of the patient. Commercially, right now, there are multiple biomarkers available to help us to further diagnose, but what causes dementia in Alzheimer's, whether it is beta or tau, that's why I think sometimes we might have to use both of them. And as I said, even today, prevention is the goal than a late diagnosis. So brain health by education, exercises, simple mental exercises, and cognitive activity is known to slow down the process. Coming to the tau imaging, it's just catching up in our country. It's a little more costly, and this probably is the images which would clearly show to you that here we are going to more precise diagnosing of dementia. This is not from my center. This is picked up from the images from the Google. What you can see is the difference of the same patient. You can actually find the amyloid plaques, the taubofibrillary tangles, using a variety of, ultimately the neuronal dysfunction can be correlated. There are, for example, differences between healthy tau versus healthy alpha beta on the top when compared to Alzheimer's and Alzheimer's tau down for the patients. You can actually make a confirmed diagnosis ante-mortem. Remember, 100 years back, Alzheimer's was diagnosed by autopsy. So what are the costs for this? It varies anywhere between $500 to $1,000. As it's getting available, the costs are coming down. Now I come to the last part of my presentation after the imaging, the other biomarkers. The other biomarkers, sadly, both the serum and CSF, they increase the precision, except some of them which is of late turning to be more valuable. The many plagues are being correlated at the preclinical Alzheimer's level with the cell loss, etc., etc. But what we are looking is a CSF biomarkers. And to some extent, there are correlations with these markers along with the serum. Another testing which we are doing in our site is the retinal deposition of amyloid by a simple biomarker test. We inject into the blood and then take a retina image. And right now, our early results seems to be correlating with the MRI findings. So that would be a kind of a biomarkers of the future. There are multiple studies which have shown that if you use 2 or 3 biomarkers, probably the precision increases. The most important thing is to catch the individuals on the left side, which can be the MCI. And what is known is we can slow down the progression of MCI to Alzheimer's disease proper, that is progression of dementia. Currently, there are multiple biomarkers, both in CSF, which probably can pick up quite early. This is one of the ones, CSF VLIP1, which actually predicts the progression in the families or the individuals. The precision rate is around 80%. The limitations is plasma levels do not indicate, but CSF markers are invasive. That's the only limitation. But this is probably useful whenever there's a family history. And the cost is not very much when compared to both the tau imaging and amyloid imaging. But a few good view is many more biomarkers are coming, both which can be tested in CSF and serum, but they are at various levels of testing at this point of time. And a bird's eye view, what's going to happen is, and I'm looking at the next 5 years, right now we need to catch them in the orange level, the preclinical level. And right now, I think there are few studies which have picked up at the preclinical level. The MRI, clinical psychological testing of memory, and tau protein can be combinedly used. But as the MCI progresses, the MRI can be beneficial, and the cognitive tests. And clinical functioning, as it deteriorates, as you can see in the end dementia, almost all the tests converge. The current approach for the various clinical trials, obviously, that's why they depend more on the tau imaging and amyloid. And there are very few molecules which are likely to come in the next 5 years. There are 3 or 4 molecules which are being tested for dementia at this point of time. So what we are definitely propose is that we need to do, at least in our parts, more precognitive testing, and especially whenever there's a family history. I think CSF imaging, CSF testing and amyloid imaging might be a kind of a precursor which we can especially predict in the, wherever there's a strong family. And in MCI2, these two are the best biomarkers at this point of time. I would conclude that using one that is just an MRI or memory testing can predict a definite dementia. But if you start using all the three, you can have 100% diagnosis of Alzheimer's. Having said that, I think we are quite a long way from now to get much more interesting biomarkers, but I do foresee in the next 5 years at least 3 or 4 new biomarkers at the serum level and the retinal level are likely to be accepted. And at probably 2026 circa, if a patient comes with a mild amnestic syndrome, we are going to do CSF, low AB2, 42 or high P tau imaging. And if these abnormal ratios persist, along with the volumetric MRI, you actually are making a preclinical early diagnosis of dementia. And then probably go and follow the patient with these biomarkers over the course. So a probable likelihood prodrome stage of Alzheimer's can be diagnosed, but this is going to be one of the dreams for the future. Ladies and gentlemen, my presentation only tells us that dementia, which is likely to be a rapidly growing disease in our graying population in our country. Right now, our graying population is roughly around 11 to 12% of the general population. And this is going to be a good area of work for the future, for our countries, in our parts of the Asia Pacific. Thank you, ladies and gentlemen, for the patient listening.
Thank you very much, Professor, for the very enlightening presentation and at the same time, I will not allow you as well. Any kind of comments or questions at that stage? I personally was interested not as a chair to follow your presentation because I do have a very strong family history of Alzheimer's disease, although the family members who had it from both sides, basically from the father's side and from the mother's side. So if you look into the chances for a preclinical assessment for somebody who are willing to pay a bit some money actually into that. So what would be your advice to somebody like me or any other person who's similar?
That's a very, I think the base to a clinical question, translating our research into practice. I think the simplest thing from 40 years onwards, that's the suggestion across the DSA. One, keep testing your memory once in a year. Keep testing your MRI, but not the
MRIs.
Not routine MRI. Is the 3 Tesla and above MRI machine. You do a dementia protocol. You actually have scores very clearly. So that is the time which you should do. But if you have high risk factors like diabetes, hypertension, hyperlipidemia, they all have to be under fully controlled. So it is preventable actually. The data right now we have is the good long-term studies have shown we can slow down the MCA progression for sure. And you know what are the things which would really benefit you? One is doing I'll give you a simplest app game called Peak, P-E-A-K.
Peak.
You start playing it for 20 minutes to 30 minutes per day. And similar kind of memory games. There are hundreds of probably tested ones. But any game is okay. That is slow down. Regular diet control, as I said, the risk factors control, but more important, regular physical activity and reduce the oxidative stress. These three factors are preventable right now. And the CSF parameters are more precise. Actually, they pick up around your 40, 50 years whether you are likely to develop or not. And there are 4 biomarkers in the CSF. But in my center, right now in my memory clinic, what we are doing is we are doing a retinal MRI too, in addition to MRI, for the family members. And I had a lot of surprises. I had a cardiologist whose 2 children who are young doctors of 40, 45. They have a significant, and they went on to do the tau imaging at Bombay. And it was showing this. And right now the recommendation possibly is to regularly follow every year from 40 and onwards. That's a very, you can say, utopian. But for me, I think 50 years, 45 to 50 years, especially when I was a high family, is really.
So, I mean, what do you think, Professor, the implications for knowing vulnerability or susceptibility at a younger age and the effect on future?
There are huge factors. I mean, I've been living for the last 15 years running my memory clinic. I have over 1,200 Alzheimer's families, and every 15 days I run the family and KRS meetings. A lot of good learning from this families. Initially it's a shock for them, as usual. Even for having one of their senior members. But if they start worrying much more about themselves than them, because as they see the deterioration. But the good news probably is, I think we are now more precise in diagnosing them, very general. MCAs we are able to diagnose, and we are following the protocol for MCA. And I told you, these kind of things, we are actually having a cohort of following MCA for some time.
So, I mean, from the psychological point of view, if somebody knew that he is susceptible or vulnerable to develop Alzheimer's disease, would he be more likely, for example, I would imagine, to feel that his memory is failing and maybe is not? Yeah.
Very interesting case of a psychiatrist who is right now 49 years. She had 3 or 4 on the mother's side and 3 or 4 on the father's side. Right now, having dementia, so she came because she knows our center is the best. And once we got the psychological, for our own surprise, there is a 20% deficit on the psychological test, and the images started showing. So we actually, though the deficit is not as much, it's like an MCA, she started taking 19 and Donepezil. Though the evidence right now is not very much for a long-term studies. Donepezil is the safe drug in terms of side effects. And even Donepezil, so she is using right now, and that for last 2.5 years, that cognitive scores have improved. And MRI imaging has slightly improved. But this is a one-off case. When we are talking about large family, this is something we need to take that aggressive.
This was quite significant family history. Thank you very much. Comments, questions at that stage? I can't see Dr. Rajesh. I should have. Oh, yes, all right. Because we don't want to forget to give you your trophy from the conference. Any more points at all? Any people who are worried to be developing Alzheimer in the future? No? Okay, thank you very much, Professor. Thank you. So, do you have the trophies? Excuse me. Trophies. Last speaker, last speaker. Usually they give at the other session. Okay. Okay, so our last and not least presentation is going to be by Professor Ahmed Malala Al-Ansari, and he's going to talk about screen-based media use among children with autism, autistic spectrum disorder, attention deficit hyperactivity disorder, and typically developing siblings, which is a very interesting subject. Professor Al-Ansari is a professor of Department of Psychiatry, College of Medicine and Medical Sciences in the Arabian Gulf University since June 2020. He holds a number of positions. He's consultant child and adolescent psychiatrist, Minister of Health. He has also been the counselor and dean for student affairs from 2008 until now. He is also holding more positions like chairman, committee of the Child and Adolescent Psychiatry, Scientific Council, member of the Higher Committee for the Care of Disabled in Bahrain, president of Bahrain ADHD Society, and he has a lot of academic contributions, published over 60 peer-reviewed articles. So please have your hands together for Professor Ahmed Al-Ansari.
Thank you, Mr. Chairman, for your kind introduction. It's the end of a long day, and I am tired, and I'm sure you are tired, and you are waiting to go for a nice dinner. So I'll try to be quick and light in my presentation. It's the end of the day. Okay. The presentation today is on the screen-based media use in autism and attention deficit hyperactivity disorder and typically developed children. In the beginning, I will review with you some of the literature about the SBM, we call it SBM, the SBM used for ASD, ADHD, normally developed or typically developed children and their mothers. And then I'm going to present to you 3 studies that we did in Bahrain, measuring the time and the type of SBM use and comparing them together, these 3 kind of subjects. First, I will talk about the magnitude of the SBM use problem. You know that the SBM has become a popular way of entertainment, social interaction among the general population. When we say about SBM, we mean the smartphone, video games, tablet devices, and television. There are 2 studies done, one in the United States and one in Canada, that shows that 47% of children spend 2 hours per day using SBM. And youth in Canada, they spend 3 hours daily watching screen. That's a bit
exceeding the recommended time. The children who are at risk of psychiatric disorder spend 1/3 of the day watching screen, and as you know, and children aged 6 to 12 viewed television for 3 hours per day. The excessive use of SPM has been implicated in the detrimental effect of socialization. I don't know what's wrong with this. Attention and school performance. Now, the SPM use among the ASD. The pathological use of SPM among children with ASD have been implicated for the formation of clinical and familial problem, and it is negatively correlated to the time spent in social interaction. And could lead to weight gain. The ASD children spend more time using SPM than any other activity except higher rate of pathological game use, exhibit a higher rate of pathological game use and have more difficulties disengaging from it. Now, the review of the literature on the SPM use among ADHD, the relationship between SPM use and ADHD yield mixed results. For example, a meta-analysis investigated the relationship of SPM use and ADHD behavior showed a small significant relationship. And other studies confirmed the association of internet use and ADHD increasing with ADHD symptom severity. The more severe, the more they use it. I think this one is tired also. The whole day is working, that's why it's jumping up and down. I'm not pressing anything. Now, why ADHD and ASD use SPM more? You use it because it's not attention demanding and it's brief, so that suit with their short attention span. 2 years follow-up studies of 2,000 adolescents with ADHD, it seems that early exposure to screen was shown to be the most significant predictor for the development of internet addiction and gaming disorder. That's very important. And other studies comparing video game playing by children with ADHD and typical developed children control did not yield any significant differences, so it's mixed result. And I think this area needs further study. Now I'll talk about the Bahrain experience. I'm going to review with you quickly 3 studies that we did in the last 5 years. But just bear with me, there are some statistics in it. The first study is investigate the SPM use among children with ASD, ADHD, and their typically developed siblings. The ASD group comprised of children aged 4 to 16, registered at ASD centers, numbers 75. It's a convenient sampling. All cases should have a sibling matches for gender and age group plus minus group of 5 years. And these are the typically developed children. The ADH group, the same age, also it's done through convenient sampling, and they have the same control group of siblings matched for gender and age group plus minus 5 years of age. They are typically developed, they don't have any neurodevelopmental disorder. The ADHD cases and control were recruited from school health center situated in primary care. Number is 50. So we have 75 ASD, 50 ADHD. The result? Here you can see that they are a really matched group in terms of child gender, the child age, mother education, equal number of housewives, and mother employment. There's not much differences between the two groups. And here is the screen-based media use in the ASD and the ADHD group. Do you have pointer here? ما في red button. The eye is green. No. It's okay. تعال. What did you do? Okay. Here you can see from this table that the ASD group, they used the tablet significantly more. Okay. And here, the ADHD group, they react violently to removing the device from them, more than the ASD group. The time spent on the screen, you can see here that's ADHD group, they spend more time than the ASD, around maybe 5 hours per day, and significantly more than the ASD group. Now, comparing the ASD, ADHD with their siblings, each one has a control siblings. Here, there's no significance between the type of device or the reaction or the amount of time they spend on the device itself between ASD and the sibling and between ADHD and the sibling. So what does that mean? That means that the family roles and what's controlling the use of the ASD is the more important thing, not the pathology among children. These are, some of them have neurodevelopment, the others they don't have. But they're both, all of them, they use the devices much more than what's recommended. The study limitation, it's a small sample size, and parents' SBM use was not studied, the parents. Mother subjectively recorded screen time, there were no diaries, and fathers were not included in data collection. So to conclude the first study, a mother reported no difference in the type of screen, time spent in viewing, and reaction to withholding the screen among cases and siblings. Children with ADHD diagnosis watched screen more frequently and reacted in a violent way and with irritable mood when screen time was restricted. 90% of children, whether they are ASD, ADHD, or sibling, use SPM more than the recommended time according to their age, according to the Manual of American Pediatric Association. Children with ADHD diagnosis constitute a high-risk group for the screen overuse, and parental role in controlling SBM use seems to be a key issue within the family. Okay? The second study. The second study, we want to know who it's used, whether the mother is working or she's a housewife. What about the children? The children of which mother they will use SBM.
Does the mother role have something to do whether she's working or staying at home? Again, a cross-sectional study involved 200 children to study SPM use of working mother versus homemakers. Each group was subjected to face-to-face interview with a guided questionnaire that examined type, duration, and reaction to withhold screen. The time was September to November 2018. The working mother of children attending local health center and 4 health-related sites were compared to equal number of homemakers that participate in the previous study, and their data is known to us. So we're comparing now the children of working mother with the children of housewife, but using comparative group from a previous study. So what was the result? Part of the methodology that the result was discussed also in a focus group of 10 mothers, both working and homemakers, to see what do they think of the result. Working mothers were similar to homemakers in demographic data, with the exception of level of education, and this was expected because they are working mothers, so they might have more university degrees. Okay? Here, as you can see, the children of working mothers, they use smartphone and video games significantly more than children of housewife mother who have ASD children. Okay? So this mother who have normal children compared with mother but are housewife of ASD children, the American mothers are using the smartphone much more significantly than mother of course, we discussed that with in the focus group and with other people. It seems, at least in Bahrain, that housewife, when they stay home, they are involved more with TV, and their children participate with them watching series of TV show. While the working mother, when she comes from work, she uses the smartphone, she uses the games, she uses other, not TV, to educate their children and help them with their homework. So she wants to use the time for that. So she's using smartphone much more than the homemakers who are staying at home. So that's the explanation we have why it is like that. So now the conclusion, children of working mothers use screen except for television more frequently and spend more time daily reviewing screen compared to children of homemakers. Children of both groups spend time that exceed the recommended 2 hours per day according to the American Pediatric Association manual. So it seems probably in the Gulf, Bahrain is an example, we are too much using the devices, the screen, much more that is recommended in the United States. Maybe they have more devices than the American. I don't know. But for example, in Bahrain, the use of internet, it's much more than the Western. The amount of internet used per capita is much more than in the United States or in the West in general. The third and the last study. Now, I'll ask you a question. Whom do you think use SPM more? Children with ASD or their mothers? Mothers of ASD? Any guess? We'll see now. This was a question raised in one of the seminar we held in Bahrain. They asked us, they said, what about mothers? You're always talking about the children, but nobody talks about the mother. Maybe the mother are using too much, and so the children also, they are using too much. So the study objective was to compare the SPM usage between children with ASD and their mothers in terms of device use and duration of daily use. only. We didn't compare if we select the time, what would happen between them. No, it's only these two things. The cases, we have 97 mothers of children with ASD that their children attended the autism centers. The comparative group, children with ASD, children aged 3 to 17 years of age, whom SBM usage had been measured previously in a similar study using similar methodology, number is 75. So we're comparing 97 with 75. Data was collected via questionnaire-guided interview with mothers. Okay? So what was the result? Mothers use the smartphone more frequently, significantly, because they control the smartphone at home. She gives them to the children. She has the smartphone. Children, they don't have a smartphone. Some of them maybe they have, but the majority, they don't have a smartphone. So it's the access to smartphone is given by the mother. Children with SD use tablet more frequently. I think tablet is more educational, and there's also cartoon, leisure. Leisure also, they spend leisure. So the tablet is handed to the children much more than the smartphone. Now this is the problem here. Both children and mother use TV equally because they sit together and they watch TV together. So they are equally. But for the smartphone, mother use much more. Now that's another issue, is that mother uses SBM for more than 5 hours per day, which was almost equal to that for ASD children. So there's no change, not much changes. Mothers of ASD, they exceed the time also allocated for them using the smartphone, and that's applied to their children. So there's no much difference between mothers and ASD children. Conclusion, mother SBM usage was high and was comparable to that of children with ASD. This is the reference for the studies, the 3 studies that we completed in the last 5 years. And I think it will be good if these studies are replicated in other parts of Arabic country to see. I mean, not in the Gulf, but Arab countries, because the Gulf, maybe they are similar. They probably will get similar result. But if they are comparing them with other countries, we'll see, maybe we'll see a difference. Okay, thank you very much for your patience. And I will be willing to answer any question, queries, and listen to your comment.
Thank you very much, Professor Ansari, for, I have to say, very interesting presentation with a lot of, I'm sure, queries and questions. There's first question here from the lady in front, yeah?
Thank you, Dr. Ahmed, for your great efforts. And the study highlighted the importance of educating mothers and training of mothers in terms of discipline and ways of dealing with the different behavioral problems in children. I know that you have a great job in having a sort of training programs to teach the parents how to deal with their children. And my question, and it's really a great job, what is next? How can we expand this experience, and what is the channels to maximize those skills in all parents?
Thank you for this question. I think it's not, there's no easy answer, because you will be against a big industry. The industry, not in Bahrain, but all over the world now, is with the use of social media, use of high technology, use it in every aspect of your life, use it in education, use it to solve to do the homework for the children, and use it at work to prepare the subject, etc. So where to